All right. Hello, everybody. My name is Alan Ndovu, and I'm a fourth year medical student at UCSF. I'm really excited to introduce our last panel, and I wanted to start by thanking all of the amazing speakers that we've heard throughout the day. Your important work in this space is an inspiration to us all, and we're really excited to see the work that you're continuing to do. For our final panel, we're excited to have deans from Stanford, UC Davis, and UCSF speak on the future of climate change and health at their institutions. Dr. Katz-Nelson is a professor of neurosurgery and medicine at Stanford University School of Medicine, where he also serves as the Associate Dean of Graduate Medical Education and Chair of the GME Committee. He has done extensive clinical work and research on the pathology and treatment of pituitary diseases, and we're really excited to have him here today. Dr. Henderson is a professor of internal medicine at UC Davis School of Medicine, where he also serves as Associate Dean of Admissions. He's worked extensively to reform medical school admissions practices to ensure that racial and economic diversity is achieved, and has led UC Davis's efforts to become one of the most diverse medical schools in the nation. Finally, Dr. Davis is a professor of medicine at UCSF and also serves as interim vice dean of education and associate dean of curriculum. His clinical interests and work have focused on patients who are immunosuppressed, the health of sexual and gender minorities, and the intersection of LGBTQ and LHS plus issues. We can't wait to hear all of your thoughts. And finally, our moderator, Dr. Judy Schechter, is a physician executive with experience in policy, strategy, and program development across several sectors. She was formerly president and CEO of the American Board of Pediatrics, chair of pediatrics at the University of Miami, and chief of service for child health at Jackson Memorial. We're really excited to have her moderate this panel, and I'll give the rest to y'all.
Alan, thank you so much. That is wonderful. I appreciate the introductions of our great panelists. This has been an amazing conference. Many thanks to all the organizers and the learners also attending. And I will say thank you. I'm honored to participate with you and to be learning from all of you. As for our esteemed panel of educators and deans from UC Davis, UCSF, and Stanford, we are delighted to be here with Dr. Katz-Nelson, Henderson, and Davis, and we will start a dialogue about climate change and health in the curriculum, about how our actions whatever actions we've taken or planned by their respective institutions can help us better heal our patients and our planet. The WHO declared 2 years ago that climate change is the single biggest health threat facing humanity. And as urgent as that is, we are all on a journey of learning about climate change and its impact on health, about our individual and collective responsibility to mitigate those changes, and learning to do that with attention to equity and justice. So finally, we're also learning how we meet this most daunting challenge of our times. With that intent in mind, let's turn to the panel of three experts and get a sense of the state of climate and health education in each of your institutions. John Davis, would you like to start us off?
Sure, happy to. Thank you, Judy. And thanks for the invitation to come speak here. This is really, I think it's exciting to be able to be at the intersection of a lot of exciting things that are happening around climate justice in general, and something that is, near and dear to my nerdy heart of curriculum and thinking about that. So I really appreciate the opportunity to come speak. I can say at our institution, our approach has been one primarily of integration. Again, this was something that was identified by our students as being an urgent need some years ago. And we definitely value the voice of students, not only in evaluating some of our curriculum, but also in co-creation. So we have mechanisms in place to not just allow, but support students in curricular efforts, pairing them up with faculty, supporting them financially as well as with academic credit. So a variety of mechanisms to allow for more of this kind of work to happen. And that was exactly how much of this got started at UCSF. The integrative approach has meant that that aspects of climate health and education have really threaded throughout, not just our pre-clerkship curriculum, but also even into the clerkship curriculum. So obviously finding homes in relevant places around things such as lung health, as well as cardiac health, which we I think many people think of when we talk about climate, but likewise aspects of health disparities and aspects of sustainability in changes that we look at in things like reproductive health and reproductive justice. How does that overlap? Thinking in terms of our inquiry program, we have an entire thread devoted to inquiry and being able to fold in questions relevant to climate health and in the work that we're doing there, and how to ask and answer some of those particular types of questions. So I'd say we're at that stage right now, which is still, I think, relatively early, but really is, that said, on its way to becoming much more robust. And I think probably the next steps for us are going to be thinking more critically about assessment. So what would assessments look like to ensure that everyone who graduates is really ready to apply some of these concepts in their chosen specialties, whatever those might be, or even in non-clinical paths if people choose non-clinical paths. So that, I think, summarizes us in a nutshell.
Thank you. I appreciate that. We have a lot of ground to cover. So Larry, can you give us an update on what's happening in your institution?
Sure. And first off, Judy and the organizers of this really amazing conference, thank you so much for including me here. And I'm just overjoyed to participate in this program. So thank you so much for that. So as you heard in the introductions, my role is I'm Associate Dean of Graduate Medical Education at Stanford, and I've been doing that for the past 10 years. And I mean, you just heard from John about ways to some of the successes and ways at least UCSF has tried to organize climate change into the curriculum. I'm going to focus more on the GME aspects of this to get you guys thinking about some of the challenges and some of the wins we could have in resident fellow education. I totally agree that we need to have a longitudinal approach to education on climate change, from medical school to residency and to fellowship. And there's a need for centralized curriculum, one that allows programs to adapt to local needs and specialty interests. For example, what may pertain to a pediatric and medicine or pulmonary fellowship curriculum may be different from that of a plastic surgery and orthopedic curriculum. And we do have pockets of programs that have integrated climate change into their curriculum, but this has unfortunately not been pervasive, but there has been a few that have been able to do this. And I want to discuss some of the challenges that we have in GME first, start with the challenges. In GME education, the challenges for education are a bit different than that in medical school. And one of the main challenges, and those of you who've been through residency and fellowships know, is finding sufficient educational time, as programs differ widely in available curricular real estate, and programs rarely have similar time for didactics, so that hospital-wide educational programs are not realistic. So we need curricula that can be adapted to the individual program schedules, didactic schedules, and needs. And the trick in GME, one of the things we try to preach and try to control in GME education, is to integrate thinking about climate change into practice, as we do with quality improvement and we do with population health. So how we can kind of create a space for practice-based knowledge that can be integrated into daily practice. Where we have had a number of successes has been in resident fellow curricula involving projects and greening the clinics, and a number of departments and program-specific projects in sustainability and greening the clinics have been successful. We have seen projects which have been individualized in training programs, such as how to reduce waste and better use of resources. Work on studying the impact on the environment has particularly been prevalent in the procedural specialties. I could think of a couple of projects, for example, that have looked at waste in biopsy kits and how to reduce such waste. And such projects can be made specific to program needs and practices. And ACGME requirements of a QI project allows this kind of work to fit nicely into such plans. And programs that have had success in publishing results, a number of our trainees have published results, so there's scholarly output, which is also inviting when doing these projects. We have also grouped residents and fellows along with nurses and medical students at Stanford to do sustainability projects at the institutional level that impact the delivery system. And the project this year has been on reducing OR waste. This is our Resident Safety Council that we created. And I'm sure that other institutions have similar in terms of institutional-wide programs for residents and fellows who are passionate and integrated on doing some form of quality improvement project. For us this year, reducing OR waste has been the project that the residents have taken on. And our hope is to promote such work within the individual programs by spreading such work in all programs. And the next trick really is to combine this work with an ongoing curriculum, which is mission critical in my view. We are committed to educate on climate change in no small part because of the role this plays on social and structural determinants on health, as Judy said at the outset. So thank you again for allowing me to participate in this panel. I look forward to the conversation.
Delighted to have you on the panel, and thank you for helping us have that longitudinal lens. Mark, maybe you can talk to us a little bit about what's happening at UC Davis.
Yeah, sure. And again, thanks, Judy, and the organizers for a great conference. I think some of the things that have happened at UC Davis kind of encompass both the undergraduate world and the GME world. I think most of our successes have been grassroots efforts. Some of, like my colleagues, for instance, we have a sustainability advocacy group that involves residents, faculty, students, and then across the undergraduate campuses. That's done quite a bit of really on the ground sustainability work, such as reducing operating room waste, as was alluded to by my colleague, kind of redoubling efforts to do recycling throughout our health system, eliminating printed prescriptions, which I think is happening everywhere, getting rid of plastic gowns and other types of plastic waste, decommissioning nitrous oxide, which reduces greenhouse gas emissions. And then a big effort has been undertaken with our food service to both donate excessive or edible food, but also to compost kind of across the continuum of the hospital, which is a huge effort. I think the curriculum, I think as John mentioned, I think we would like to be more integrated. We have a couple of courses, one required 4-hour course that teaches about clinical climate health and disparities, and then a 2-week elective course that's taught by Dr. Margolis, which is a population health, very popular. 50 or so students a year take it. So I think, as I've alluded to, it's something that students and trainees in the next generation demand. I think maybe I think those are kind of what we're doing now. The research that goes on at UC Davis, being a big ag school with a big, very prominent veterinary medicine school, has an approach that really looks at health in many ways in a more holistic fashion than we do in human medicine. That is, they really incorporate elements of the environment, animal health, waste, climate, the whole ecosystem, if you will, is a fundamental approach called One Health, which is the big research center housed at UC Davis, which is probably the most, maybe where we've had the biggest success. That is in interdisciplinary research that has to do with the effects of climate on health. Maybe I'll stop there. That's probably enough to give you a sense.
That's wonderful. I'm going to ask you to keep the mic for a minute, Mark, because sure. I want to focus us a little bit on disparities directly, and it sounds like your food program is part of that. Disparities cut across every area of health and healthcare and can be compounded by climate change as well as our attempts to adapt or mitigate. So for each of you, but Mark, if you'd start, how is UC?
Yeah, thanks. I think that's a hugely important and, if you will, existential question. At our institution, as was mentioned in the introduction, we have a medical student body that is, very, comes from many different vulnerable and underserved communities. One of the communities that's been affected, we all have been, but in a greater sense, has been the Native American and tribal communities. And we have a program that trains medical students to serve they're often from tribal communities in California, but gives them supplemental training, curriculum, and then research experience so that they can eventually serve California tribal communities in their future health sciences career. That program is 6 students a year, which has been mostly clinical training, but our intention in the future, based on, you know, the need and some of our assets in terms of interdisciplinary research, is to add a 5th year to that program. It's 4 years, like quote regular medical school, to add a 5th year that's a master's year focused on public health of Native communities. So where they would do a project essentially involving environmental justice, environmental health. And that's a very, again, energized group of individuals whose personal lives and families have often been affected, even more so than we all have been. So I'm most excited about that. And I think it leverages the tremendous assets and lived experience of some of our students.
Thank you, Mark. Larry, John, do you want to add on how you put equity center in climate change education?
Sure, happy to chime in there. So I think along the lines of exactly what Mark was mentioning, we also have a couple of tracks that are designed for those who have a commitment to serving specific marginalized and minoritized communities. So we have the San Joaquin Valley Prime program, as well as a Prime Urban Underserved program. And I think as exactly as Mark was mentioning, for those who have a commitment to serve those communities clinically, there are additional things that knowledge, skills, attitudes that we would hope that those graduates would have. And we want to make sure people are ready to really provide that equity-centered care for those populations. And I would say there is a focus on equity that I think all graduates should have. And so we have a program focused on how to sort of shift the curriculum into including that anti-oppression lens, understanding the systems of power that work to marginalize and minoritize different identities and how that can impact healthcare. And so this so the concepts that I think are central to climate justice are absolutely egocentric with those types of efforts in anti-oppression. And so that is part of what has facilitated integration of some concepts into the curriculum so far, and we hope will be successful with parts of the curriculum that are remaining.
I could add to that, to my colleagues have said is promotion of advocacy type of conversations. And for example, Lisa Patel, who's on this call somewhere here, has been really terrific on that in the pediatric realm at Stanford, and just promoting advocacy on the part of their patients and their communities. We really saw this play out this past year with the RSV crisis and the despair and the disparate impact that had upon different groups. So enabling advocacy as part of the educational paradigm is what's been, I find really interesting, and something we really do want to promote and have promoted, want to do even further to kind of engage the trainees, that this is the medical students and trainees, that this should be part of their career, should be always thinking down the lens of advocacy.
Thank you all for adding to that. There's a lot going on at the 3 institutions, and there's still a ton more to be done. Academia, in my experience, is not super well known for its rapid change. Maybe you feel differently, but realistically, let's assess then the obstacles to moving forward. So thinking about what are the most significant barriers to expanding climate education at your institutions. What are those barriers specifically, and what's being done to address them? Larry, do you want to start us off?
Sure. I think one of the biggest barriers that we see is having a centralized office / resource for this, is having dedicated personnel who are going to take this on both at the school and the GME level at a longitudinal approach. I wouldn't say it's a barrier that people don't want to do it. We just haven't really risen to the challenge of doing that quite yet, of having both the financial resource as well as the personnel. We definitely have faculty and students who are very interested in this, and there's no question, a number of them are on this call now. The challenge that we have is just centralizing these resources, in addition to integrating with what's happening at the university level on climate change university, but so we could try to connect what we're seeing at the medical center and the medical school with what's happening at the New Doer School of Sustainability, and to try to link these different avenues up with a centralized way to approach curricular development as well as potential sustainability projects. That's where we are right now. I'd say is our biggest challenge, is how to integrate with what's going on at the university level, as well as having centralized personnel and resources available to really take this on, instead of people doing this as part of their career, as part of their week, have people dedicated in a better way.
John and Mark, do you find the same barriers or something added?
I guess I would add, I mean, I agree that it's too important to be an add-on. I think one of the biggest curricular barriers is that it's too important to be an add-on for medical students as well. And the medical school curriculum is so packed with stuff that I think it's extremely challenging to add anything. And I'm sure John, I think he spoke a little bit about the integrative approach that's used at UCSF, but it's really hard. It's a sort of a zero-sum game. And I think we medical students they need it early and often, and I don't think we're doing enough in that regard.
I will just hear to that Mark said. You know, that this is sort of the classic curriculum conundrum, which is again, there's so much to teach in so little time. And I think, again, the integrative approach is one way of looking at this. I think the other thing to consider is that at some point we can't say that that your training is complete at the end of the 4 years. And so we're going to have to look at education as, you know, as a lifelong practice. You know, we've adopted that from the ACGME back when those competencies were developed. And lifelong learning is there for a reason. And I think in the past, it meant one thing in particular about don't let your training stop. You'll need to continue updating things that you've learned before. But I think if we look at it as a continuum, understanding that concepts around climate justice and climate health are really going to have to be acquired and implemented as part of a longer arc, not just within the first 2 years or even within the first 4.
Thank you. That's super important. And I'll give an extra shout out to somebody Larry mentioned at Stanford. Lisa Patel was part of a group that wrote in for maintenance of certification that got accepted by the American Board of Pediatrics. So it is, we agree that is important to do lifelong. What the themes you all are bringing up are consistent with the start of this conference, that climate change is an area where collaboration, not competition, is super essential. So how can UME, GME, other healthcare professionals, leaders in education across the board collaborate to ensure that trainees receive comprehensive, longitudinal climate education that'll really make a difference? Open to anybody.
Maybe I'll lead off there. So one thing I think would be very helpful would be some aspect of standardization. And what I mean by that is if we had clearly articulated objectives that all medical schools shared, then those might be at least a starting place for our GME colleagues to be able to pick up and move on with things as articulated as part of let's say milestones that that the different GME programs have, et cetera. And I think we could then build off of things from there. And for right now, I think we're still kind of at the stage of trying to figure out how these things are going to fit in within the UME landscape, to make sure that our graduates are able to meet at least what objectives we've adopted and generated within our curriculum. I think, again, more standardization will lead to more, I think, incorporation. I think the other thing is additional commitment of resources to general repositories, again, of instructional materials. These are things like MedEd Portal, and I believe there are some on the website that, again, I'll give a shout out to several folks at UCSF who've done some of this, including Heather Whalen and Alan Ndovu, who did the introductions early on, and previously to Carly Hampshire. So I think these are being curated actively, and I think the more we have of something like that, exactly as you mentioned, Judy, a collaborative effort where we can all share some of these resources, the easier they'll be implemented, and therefore hopefully become part of the standard repertoire of what we deliver.
If I can add to that, I totally concur on the collaborative approach and standardization of the curriculum and of resources. I love that idea. I would add to that, there's also needs to be both a top-down and a bottom-up approach. There needs to be commitment from the institution, which I believe our institutions do, but this is, I can't speak for other institutions across the country, but there needs to be, from the dean on down, a commitment to pursuing this avenue, which again, in our institutions exists, but not in all, and I can't speak for others. But it also needs to be a bottom up. And I say that because in my time, I've seen various parts of education that may now seem like it's standard and it's been there forever, but it wasn't. Example being how to communicate, just basic communications, how to give tough news, how to communicate dialogue, such as how to give informed consent. When a number of us on this panel here were training, this type of education didn't exist. And in fact, when we've tried to bring that into various levels of education, in not too distant past, there was resistance because it was felt that there was other physiology and other aspects that had priority in education. But once the faculty got a glimpse of how important this was, in addition to the trainees and students saw, then it became more integrated into culture. And I think from the faculty standpoint, in our institutions, faculty likely would, the vast majority of university would agree that climate change is a very important problem. But that's different from this next step of saying, let's take this into the curriculum and let's prioritize this over some other aspects, given the limited real estate that's available for curriculum. And so I think more education on the general faculty, as well as a top-down approach from would also add to the ability to make this more of a priority amongst the institutions. And also from central bodies, central national bodies support. So that would be the addition I would add to the standardization approach that John mentioned.
I'm going to get back to your last point in a minute with a question that we have coming in. But Mark, do you want to add something there?
I mean, I couldn't, not much to add. I mean, I think the bottom line is, I don't think we do collaborate enough. We don't work very well together sometimes. So I think the next generation maybe will do better. And this is a great example of it, this conference. I will say, having run GME programs before, that the best way to get something done is, and I hate to say this, I don't know, but I guess it's being recorded, is to require it. And so if that's so complicated, right? Am I going to say that you all should write to the LCME and make them require it? I guess that's one way, would be requiring, accreditation requirements is how GME programs respond. Honestly, it's how medical schools respond most quickly. So maybe some form of that. I don't know exactly. I don't know. John would probably kill me. We don't want to do this, right?
Yeah, I will say that was something of that nature. And again, I'm happy to get into any details if people would like it or would like ideas of what to ask for. But yeah, the idea is Again, there aren't many sort of hard baked into the LCME requirements for medical school training. However, they do have an annual survey, what we call the LCME Part 2 survey, that we fill out, where they ask about select topics and they say, where are you covering this? And just putting that on the radar screen is enough often to get people at least thinking about it. And I will say that, one of our first steps was generating a landscape assessment, right? About where are we covering anything to do with climate health and justice in our curriculum. And so even that simple step can be enough to prod curricula into action. So I agree with you.
Yeah, so I think you're hearing strong endorsement, Margie Chen, in terms of your question about LCME and some steps along the way to get us there. Thank you for that. In that vein, actually, you all know that this has been very bottom up with faculty and students who have been volunteers to make the progress we've made so far. But the expectations for that are starting to change. So regulatory bodies like the Association of American Medical Colleges has put out a number of pamphlets, assessment surveys on this. The Joint Commission now recognizes the centrality of climate change action. Climate change education is becoming more and more an education, whether it's an expectation, whether it's led by students doing the PHR or other initiatives, including the White House Pledge, which encourages all our institutions to reduce our greenhouse gas production and to report on our project progress. And institutions that we heard from today, such as George Washington and Harvard, which are investing hard FTEs and making firm commitments. So given all of that, what are the next steps for UC Davis, UCSF, and Stanford in terms of the commitments that your institutions are starting to talk about as they consider how to advance meaningful, robust, sufficiently resourced learning to improve patient health and equity?
Again, I would draw on the grassroots efforts, if they are cross silos, if they cross UME and GME, if they cross campuses, if they just have greater power. And I think what I mean by that is the tangible work accomplishments at our place having to do with reducing, again, waste of all sorts, into the air, into the environment in all senses has been, as a result, I feel there's been more progress and faster that way. So I think we need more investment. There's no question about it. But when you have enough of a movement, right, then especially at a medical school, students and residents actually have, I'll just say they have power to leverage that, to use that power to then maybe stimulate the investments you're talking about, Judy. Because Harvard and I forget who else you named, but I mean, some people have sort of deeper pockets, and so it's easier for them to invest in something. I think we all need to be investing in this. So it's just on a broader across the medical education space. But I guess I'm still saying grassroots is better at this point. It's related.
I would concur with that, with what my colleague Mark just said, in that, as Judy, as you described in your introduction to that question, the stem was that many people are doing this part-time and they are contributing in some ways. Whether or not they're receiving any FTE support for this, many are not, and they're volunteering to do this. And I'm now hearing from several departments now, who have requested they'd like to have a dedicated person who can kind of help develop curricula for that department if they're keeping it separate. I'd rather have a generalized universal curriculum, but this is coming from the grassroots up, where departments are asking for support for the faculty, both to help develop kind of personalized curricula for their specialty, as well as help support some of the projects that they're trying to lift off the ground in sustainability. there needs to be, the resources need to be channeled in these directions, both for leadership, who's ever going to be putting together this curriculum, as well as within the departments to help adapt it, the curriculum to their needs, to their specialty needs. So the grassroots is a super important part of this, to Mark's point, and I concur totally.
I will chime in and third that, which is I think one important aspect to the grassroots effort, part of this is that, to me, it represents certain voices that need to be at the table. So again, I agree that there needs to be top-down buy-in and top-down support for these things. And so, I mean, as an example, at UCSF, we have a recently formed center for climate health and equity, and I think Dr. Ariane Tarani is here, who helps co-lead that. And I will say that effort really has to be informed by various voices, including community, including the community in the academic medical center, as well as outside of academia. So again, I think there's a lot of voices that need to be centered as part of these efforts. At the same time, another thing that I think is important is when thinking about allocating FTEs, for instance, I think we have to be very, very careful about one person bearing, I think, the responsibility then for all of this type of work. I think exactly as Larry and Mark were mentioning, this is responsibility of all of us. And so where there are FTEs already allocated, I think it's important to ask, how is that being done through the lens of whether it's healthcare sustainability and climate health and climate justice, et cetera. So I think sometimes, yes, we need FTE in order to create new things, or to, for instance, in my area, build new curriculum. So when you're writing curriculum and developing assessments, that makes sense. And there are plenty of other people who have FTE who are developing curriculum and doing other types of things. And I think it's incumbent upon all of us to be able to ask, how are we embracing this as part of what we do every day? We're already getting our FTE for. Because otherwise it can become very, very easy to sort of say, well, that's not my responsibility. There's a person over there getting their FTE for that, so I'm going to let them do all of that work. And so I just think we need to make sure that we're being thoughtful about how we deploy resources when we're leading some of these efforts.
No, I think that's a great reminder. Mark, did you have something you wanted to?
I was just going to add to something, because John said something I think super important, which is having people affected by, all these healthcare problems at the table. And that's not what we do. That's why representation from marginalized communities matters in medicine. But we're, medicine's an ivory tower. That's just not how it works. So the more we can, again, have representation from communities that are affected, again, we do this by having, a representative medical school and trying to enhance representation in the workforce. But I also think we do this, in the boards of community health centers, when we bring patients and people who live in a community to be on the board that runs the thing. That's just not how we do it in a big academic medical center. So I think that's what John was saying too. I just want to amplify it.
Yeah, big head shake there.
I would just add also that to what Mark just said, on top of John's comments, of it also comes back down to the advocacy piece, which is really important here too, of advocating for our patient populations. And I love the way that Mark just articulated this, of ensuring that we have representation so we could really understand the impact on our communities. And again, advocacy. And I think this is something that we should be stressing in all of our curricula, that this is something you can bring into your daily practice, advocacy, and of how to integrate this in your thinking in patient care. So, and through the career. So that's why I just love the way that was articulated.
Let me remind everybody listening that the panel would love to hear your questions and to answer them. So go ahead and write anything you have into the Q&A. And I'll also repeat something that you all just said, common themes there around the power of our learners. I don't know that they always feel that they have the power, and maybe you can speak to where that is and how they ought to use it. Maybe we stretch ourselves a little bit, because you're asking for grassroots up, you're asking for representation of the table, and some of them may not feel they're always invited. And you're speaking about advocacy. So how should they use their voice to best make this change?
So many thoughts, but you're paying tuition to wherever you are. If you're a medical student, maybe then I think you, as a paying customer, if you will, can, I don't want to say demand, but ask for a place at some of these tables, whether it's going to the office hours of your dean or dean-like person. Those things are, I think that's something that I would encourage you. Just ask for a place at the table at again, office hours, a meeting, a curriculum meeting, and join. I think it's what Larry was saying. This is part of advocacy, and all of your career as a physician, you're going to be an advocate for your patients, but you're also going to need to advocate for change that needs to be made in your organization. So that starts, to me, in medical school or in professional school. It should or could start. And again, I think you'll find it's not, you'll be well received. Again, I'd say, because you're paying to be there, and it's your right.
Yeah, I'll build off of what Mark was saying there. I think most curricula, and this is at least sort of a soft LCME requirement. Most curricula will have some way for students to be able to give input on the curriculum and usually participate in the curriculum governance process. And so that is one place right there where the student voice can be heard. And again, sometimes it's representative. So whether that's specific elected or appointed students are on some of these committees, you have representation there, and that's one way of advocating for inclusion of particular topics. I think the other thing that can be really helpful is partnering. So again, many students are at large institutions, and it means that in residents and fellows and faculty, there are some who are allies. And so as you're looking to make change, finding those allies, coming together, and being strategic about what are some things that we might be able to do and move the needle on can be helpful. Likewise, and usually there are some, if any of the allies are within the curriculum itself, that's an even more powerful way of curating change, because there are some faculty who will be happy to lead some of that effort, and then through their own participation in the curriculum be able to spread change through to others. I think then probably the next way, and last I'll mention, is at a slightly higher level. Again, we've already made allusion to things like the LCME, and Judy, you had mentioned some of the white papers that have come out and other guidance that has come out. Again, even if it's not necessarily, even if it doesn't have the teeth of regulation, ensuring that there are some of these guidance documents that can at least be shown and leveraged to different curricular people who are responsible, people like curriculum deans or others, is a great way of helping move things, I think, along.
Thank you. Go ahead, Larry.
Yeah. So you just heard my colleagues speak about at the medical school level. I could just take the bill from the GME level, and that it's been really interesting watching the evolution over the last few years about the interest in climate change. And a lot of it has come from the residents themselves who have witnessed what they have seen as waste, as seeing the impact of the Northern California fires on health, who have witnessed this firsthand in their management and have been asking questions about what we can do and how we intersect climate change with our care. Um, and what has resulted in this has been this cross-collaborative, cross-departmental work. And I want to thank Barb Ernie, who's on this call, and Lisa Patel, who we heard her name a couple times now, who's been really important at Stanford for promoting these ideas. But some of the ideas have come through, for example, from residents. This is from residents. Like, for example, during the coronavirus times, when we moved completely to virtual care for a lot of the programs, well, what's the impact of using or not using virtual care, or, for example, on the carbon footprint? There's a residents bubbled up to us, and they wanted to look at this as a research project. And so there's just some ideas that the residents have had. And the other part of this is residents, and along with the students, with the residents and fellows, we've been trying to promote a culture where they can bring this up to their program directors. And we've actually, so I run a program director meeting every month, and once a year I've tried to bring in examples from departments of residents who are interested in this, to let them demonstrate what kind of projects they're doing, to get the program directors engaged in this, so the program directors can go back to their programs and try to incite interest and engage on climate change. So it becomes bi-directional, that the program directors can ask the residents, let's say, this is cool, look what dermatology department's doing, look what plastic surgery department's doing, and we could do something similarly. And so it becomes bi-directional. So the residents feel very engaged in bringing ideas up to them and from top down as well. So we have found this to be useful in this process, but residents and fellows, along with the students, need to have a voice, need to bring this to the table, and we just need to create avenues that they can do this.
And Angela is asking a couple questions, which I think have to do about the collaboration we've talked about. And Larry, you were just talking about across departments in terms of content champions and the use of content champions in developing that curricula, and coordination with other schools. I think ME associations maybe are medical examination. I'm not sure. Do any of you want to address that more directly?
I mean, I think, go ahead, John. Larry. I mean, I think it was mentioned earlier that the American Association of American Medical Colleges, which is a large group, it's sort of the group of medical education leaders, I suppose, has already called for this, but that's not the same as having requirements it just the accreditation requirements have much more teeth in them. So that's I guess. And how do you influence that? I'm not really sure. I think we're moving that way. So I don't know, it's a tough one with the medical education, with the trying to make requirements. I was trying to look at Angela's question. Was it? Okay.
It's really interesting. It gets to this bottom down, top up, bottom.
Yeah.
Top down kind of thing. I would, and as somebody who's been in that world with the certifying board, if the students are demanding this, if the trainees are demanding it, if the curriculum starts to develop it, that can actually lead the train just as much as it being on an exam, from my perspective. But you as educators, let us know if you feel otherwise.
Well, so I will chime in and just sort of say that I think that is a good point, which is, so if we're specifically talking about medical exams, that is another way to effect change, which is like, if we can get content of that type on, the USMLE, then that becomes an automatic. Now, again, it usually is more about medical knowledge than it is about, let's say some other competencies. But, even within that domain, being able to ensure some baseline level of medical knowledge mastery of content related to climate health, et cetera, I think that is one way to affect change very quickly, because that word will spread. And then next thing you know, all of the commercial resources that are out there will contain some of this. And many medical schools that pay attention to that will then will suddenly have a need for something like that. So I do think that is one way of effecting change, even if it is over sort of a limited set of competencies.
Thank you. I love all the different ways we can attack this. Robert Gould has asked a question which might work for y'all in California and not everywhere in the United States. But is there a role for the schools to solicit governing boards, the governor, legislation, regents, donors, to provide the resources that are needed?
Well, I'll start with the last part of that phrase, which was the resources that are needed. And that's where the resources are. So I think if you were thinking strategically in that way, of course, going to the governor who has, political aspirations, et cetera, is probably a good idea. I think it's a great idea, actually. Yeah, as to who does that or who's most effective, I'm not sure I know, but I like that source for the responsibility for the citizens, etc. So I like the idea. I don't know who. Maybe I'll let my colleagues answer who should do that.
I can just say that, by the way, I thought ME was medical examiner, so I'm glad to know it's medical exam. So I was trying to understand that question. I think some of it comes down to the degree of grassroots interest and universal acceptance and requirements. I mean, this has been said several times now in the past hour about if there were such requirements in LCME. The same goes for the ACGME. The ACGME does require some thinking in this path, but not really. There are no discrete requirements on climate change curriculum and practice. There's requirements on quality improvement projects. There's requirements on thinking about social discrepancies, disparities in care. I mean, there's all those requirements are there. Regardless, there's common requirements across GME with this, but there's no discrete climate change. And if this were to become more of a required educational paradigm within all the programs, then there will definitely be mandated to have resources available for this. And those resources would either need to come from the public and private institutions or from the government. But that would require the grassroots campaign. So again, coming back to the point we made earlier, the more we can make this a required aspect of the curriculum, the more we can create grassroots support, the better chance we would have for more funding from external funding, whether it's from government or from other institutional resources. So these are all parts, I think, that the steps we need to take up that ladder up to get that funding.
So let's imagine that we're there. Let's imagine that we have a somewhat standardized, as John kind of discussed, curriculum at all of your institutions, that we understand what that means in terms of a competency-based medical education in climate change. How do we measure its impact? And are any of you doing that now? If you're not, imagine what would that look like? I can see your big smile, John, behind that beard.
Usually it hides that sort of thing, but so I mean, you're kind of inviting us. So I'm going to nerd out 1 second. I mean, so you're inviting us to rethink what we often use in medical education as sort of the Kirkpatrick scale, which is thinking about, like, was the curriculum acceptable? Did people have some learning outcomes that they got? Were they able to use that in practice, and were they able to make some changes? So if I sort of reimagine that slightly, what you're asking is can we shift that to say, am I having an effect on primary markers, secondary markers, or tertiary markers in climate health, right? And so asking, can we look at those? And so I think here is where really integrating with the work of our health systems is super, super important. I mean, again, if I'm thinking about Like, let's say I'm giving some education over here about some aspect of patient care. And sure, I can ask if it was, if people felt okay with it, as it was being delivered. Did I like it? Did I learn something? So I do a test, and then I can go to the health system and look at things like like electronic health records to see if it was actually put into practice in the health system. Likewise, as we're looking at JCAHO and others, being able to have requirements for metrics, or key behavioral indicators associated with health systems, incorporating climate health, sustainability, et cetera, into their practices, we can see then if we are moving the needle on any of this with respect to what we're doing. I'd say that's one piece of it. One that we're already kind of doing is looking at, so I had mentioned we have, as an example, opportunities for students to get involved in projects. And so, we have a health systems improvement project that's required of all of our medical students. And so the extent to which those are involving and considering aspects of climate health and healthcare sustainability, or focusing on those even, is being looked at. And we can likewise look at our students who do inquiry. I mentioned that before. And so if they're doing a funded year off, or if they're doing projects, scholarly projects later in their time, how many of those are focusing on this? So those are things that we can start to look at that are kind of baby steps to get us there. But I think ultimately integrating with the health systems and being able to look at that change that we're having at a higher level is going to be important.
Those are fabulous suggestions, and thank you for that, John. Given the hour or the minute, Larry and Mark, you're not in the hot seat on that one, because I'm supposed to toss this over to Dr. Weiser. This has been a great education for me, and I hope for others. Dr. Katz-Nelson, Henderson, and Davis, thank you very much for being with us, all you've shared, and all you will do in the future with us for climate change.
Thanks so much.
Thank you.
Thanks a lot.
I just wanted to very quickly say thank you to everyone. When we started this 4 years ago, I don't think we had any idea that we would see so much success, so many gains, and so much support from our leaders. So thank you so much. We're grateful to all of you and all of the faculty, staff, students, residents that have helped to make this a success each year. And I'll turn it over to Sherry. Sherry,
Sherry.
You're muted.
Thank you. Sorry about that. I was just thanking you, Lisa, for your leadership in making this, in starting this 4 years ago and bringing us along. So I just wanted to take a moment to thank you all for joining us at this year's NorCal Symposium. We are so appreciative of all the wonderful panelists we've heard from today. I also just wanted to take a moment to thank the amazing students, faculty, and staff who have made this possible and have been working tirelessly. These include Eliana Kim, Pedro Hernandez, Alan Ndovu, and Hossein Tagabi as students. Wonderful staff. Gail Lee has really played a major role here. Eliza Hayes as well. And faculty, Katie Brooks, of course, Lisa, Maria Zlotnick, Barbara Emery, Angela Haxu, and William Pevek, and Tomiko Katsumoto. And as we have heard today, in the face of the biggest existential threat of our lifetime, there is now a historic opportunity to transform our societies. I'm really heartened and inspired by the pioneering education work of all of our panelists, which is really paving the way for a healthier and more equitable future. So thank you very much for tuning in with us. This will be available online. We'll send off links, and thank you all for joining us.